Hello, everybody. Hope you're holding up in this unprecedented time in medicine. With COVID-19, because of the rapidity of the pandemic, there's so many uncertainties with management at this time. Throw in shortages of PPE and ventilators and worries about spreading this to our loved ones, the economy tanking. I don't even know where to get started. But we're all in this together, and so I decided to make this short video about how to think about and practice POCUS in patients with COVID-19. So this is a high-yield video that assumes you know a little bit about POCUS, including lung and cardiac and IVC ultrasound. First, we'll go over the CDC recommendations for PPE. Then we'll go over some ways to protect the machine that are recommended by the ACEP ultrasound section. Next, we'll go over a high-yield lung and cardiac POCUS exam, followed by some common findings that you'll see in your patients with COVID-19. And last, we'll go over step-by-step how to disinfect the machine and yourself, and then we'll end with some research questions. First, with concerns about droplet versus aerosol spread of coronavirus, the first point is just to limit your exposure. I'll make a strong argument for doing POCUS with your initial assessment of patients, especially the sickest, because it can really guide management. However, in those quote-unquote worried well, and especially as the incidence of COVID-19 increases in your area, and the pretest probability also increases, it may be better not to perform any imaging. However, realize also that the chest x-ray is only positive in about a third of patients. And by the way, I do have references at the end. You all know that CT has been really useful in demonstrating pleural irregularities, those ground glass opacities and bronchodavascular changes in COVID-19. And you also know that the lesions are typically peripheral and posterior and lateral in distribution. And this is why POCUS also performs so well, because the findings are so close to the chest wall, and they are similar to normal interstitial findings that you see in POCUS. We know that POCUS has greater than 90% sensitivity and specificity as compared to CT for these findings. Hold up there, Caitlin. Gone are the days where you immediately rush into the room of a hypoxic febrile patient. In time of COVID, the first and most important thing is to protect yourself. So the CDC recommends this order of donning. First gown, then mask, then put on your face shield or goggles, or both if you have them, and the last is to put on your gloves. So some might ask, why put on the gown first? Well, it's easier than trying to fit the gown over a face shield or mask or PAPR. Caitlin's also wearing a bouffant to minimize the risk of an aerosolized droplet landing in her hair. The last check? All good. Next is the machine. First, you want to check to make sure that only the bare essentials are in the cart, which are disinfection wipes, probe covers, and gel, nothing else. Ideally, this check should be done at the beginning of the shift. And by the way, no, the coffee creamer wasn't really in the cart. Now, this next step is optional, but really important when there is an aerosol generating procedure taking place, such as when patients are getting nebulizer treatment or BiPAP. Also, I think if patients are coughing up a lung, I think I would do this too. Others have posted that they have used trash bags, etc. There are a lot of options out there, but just remember that you just want to protect as much as possible. And sometimes those trash bags really blur your screen, or you might not be able to use a touch screen. So this is a gown technique. So first, because of concerns with infection control, you really want to think about batching your exam and testing with patients with suspected COVID. You want to be able to go in there and do only as needed for your diagnosis and get out. You can really choose only one probe, and we really recommend that it is the phase array or cardiac probe, and this is for two reasons. First, it can identify common lung pathologies associated with COVID-19, as we mentioned. Second, you can use it to assess LV systolic function and IVC, which are really important for initial assessment and serial assessment. So here we demonstrate using a probe cover. Remember to put some gel on the probe, first to avoid air artifact, and also to cover the cable as much as possible. Also remember that while we use a sterile cover, we're using it really to protect the probe, and that this isn't really a sterile procedure. One last thing, on the same theme as infection control and using your time efficiently, make sure you have the study information loaded on the machine before you walk in the room. So you guys know that there are several lung protocols out there, the FATE exam, Volpicelli's, 8 lung zone, Liechtenstein's blue protocol, etc. These are like your Sunday morning strolls in the park exams where you can really take your time, grab a cup of coffee, sit and digest what you're seeing. With COVID-19, you really need to be efficient. So that's why the high yield zones are lateral and posterior, at least in the diagnosis phase. So here we're starting with the right lateral, and we find a nice pleural interface with the normal A-line profile here. Now we have the left lateral. Notice that we're too inferior, so we'll slide 1 or 2 intercostal spaces up to find the pleural line, and we have that same profile. So you can also take a look at pleural effusions. They're relatively uncommon in COVID. So if you're able to take a quick look at the spine sign crossing the diaphragm, that might help. Here's another tip. We really want to visualize a crisp pleural lining because anisotropy can make it appear blurry. So just slightly tilting or fanning the probe can turn this window from blurry to a new A-line profile right here. So if you see interstitial pathology on your lateral zones, you really have all that's needed for the diagnosis. You can probably skip the posterior zones and move to the cardiac and IVC to really assess for a cardiogenic reason for the interstitial findings. Now, if there are no lateral findings and you're really doing this exam serially, you can examine the posterior zones. We'll go to the right first, and then the left. Now, for patient positioning, you may need an assistant to help. If you time your exam with your attending or resident, nurse, or RT, they can really help with this. You can also ask the patient to roll in lateral decubitus or even prone for both windows. So I recommend also taking a quick assessment of both systolic function and the inferior vena cava. Why? Well, for one, if the presentation is atypical for COVID, and maybe there's no such category, but let's say the patient is elderly but not from a nursing home and doesn't have a fever or myalgias, and you visualize reduced systolic function and a plethoric IVC, well, that really points towards the cardiogenic cause more likely. Also, if you're on a medicine or ICU team, there's also about a 20% chance that the patient might develop acute cardiac injury, and so checking their systolic function and their IVC variability may help you to diagnose it earlier. Here's a parasternal long axis, but you can also try a parasternal short or even a subxiphoid 2-chamber, especially if you're finding it hard to find good parasternal windows. I like to go from the short axis of the IVC and rotate the probe 90 degrees clockwise to find a long axis here. And you can also see the hepatic vein inlet. That confirms the IVC. Great job, guys. Okay, so you're done with your exam. Now it's time to doff and to clean. First thing is just to move away from the head of the bed where you're likely going to be exposed to aerosols. So move at least 6 feet away. Then you want to disinfect the machine first while you still have your PPE on. And that means removing the probe cover as well as the gown from the machine, and then wiping the probe all the way to the cable end or to the terminal itself. And then you want to wipe the exposed areas. If you're using the gown, it's really the monitor and the touchscreen as well as the frame around it or the barrier or the hold. And now it's time to remove your own PPE. And the CDC recommends 2 ways to remove your PPE. I like this way. This is to remove your outer pair of gloves and your gown at the same time, and then to use hand sanitizer. Then you would remove your face shield without touching your face. You kind of like lean forward, and as you take it off, you move it away from your face. Then sanitize your hands again. Then this is where you want to remove your mask. If you have an N95 underneath, this is just removing your surgical mask. And then you want to sanitize again, and you are ready to go. This is Caitlin demonstrating this double gown and glove removal. She's got 2 sets of gloves. First set of gloves come off, and remember that on the inside of the gown, everything is clean, kind of rolled up like this, so that you're just touching the clean side, and you want to dump it in this way. And you sanitize again, and then you remove, if you have a bouffant or your goggles, just kind of serially remove one item at a time and sanitize. And that's what she's doing right now. Oh, by the way, if you hear my kids in the background, that's because we're all on lockdown. Thank you, COVID. The POCUS findings, as we know, are not specific for COVID-19. Repeat, the findings are not specific for this disease. Rather, you can see them in interstitial syndromes like ARDS or cardiogenic pulmonary edema. Here you can see multiple B lines, maybe a large confluent B line here, And you can also see that the pleura is irregular. It's thickened, it's kind of ratty looking. This is what you'll look for. The next finding is something called a subpleural consolidation, and you can see these as these anechoic wedges just deep to the pleural lining. Now, subpleural consolidations can also be seen in PE, which isn't surprising because in some reports of patients with severe COVID, they have a prothrombotic state and may be more susceptible to thromboembolism. And then the last finding is are these alveolar consolidations, which is seen as hepatization of the lung or a liver-like appearance to the lung when the parenchyma around here is fluid-filled. You can also see the ultrasound equivalent of air bronchograms, which are these dynamic air molecules in the bronchial tree. See these? So what may be important about POCUS in COVID? First, we know that CT findings typically are in the periphery and involve lateral and posterior areas. Second, we also know that CT findings change with disease progression, so our ultrasound findings should change as well. But this hasn't been studied prospectively, at least in the large trial. So this is our last slide. This is our proposed POCUS integrated observational study for COVID, or PIOS-COVID. We already know that lung POCUS is amazingly good. Now we need to prove that it makes a difference in terms of diagnosis and prognostication. Our first question is there a sonographic profile for these patients with moderate or severe COVID? This could potentially help us to reduce our testing and help us to arrive at that diagnosis more efficiently. Next, in these patients, can we predict which ones will get worse and which ones will improve? For this, we need serial POCUS exams along with other clinical data. And specific questions are, knowing that about 50% develop ARDS, can we detect that early on, prior to worsening hypoxemia, by showing that POCUS will involve the anterior lung zones? The second question is, if we see worsening alveolar consolidation, does that predict the need for alveolar recruitment measures like increasing the PEEP or prone positioning? And our last research question is, knowing that acute cardiac injury occurs in up to 20% of patients with COVID-19, can we predict that early in the time course by detecting worsening systolic function? Remember that these patients, if they're on the ventilator, they can't tell you that they have chest pain. And also, even if they are alert and oriented, they may ascribe the symptoms of ischemic chest pain to their COVID symptoms. So if we can detect this earlier, we may be able to prevent these unexplained cardiac arrests that are reported in patients with COVID-19. Thank you to Drs. Caitlin Odenkamp and Tom Akey for being in this video. To all the frontliners, it is heartening to know that we are all out there sharing tips and fighting this pandemic together. Honestly, it may be a long slog, similar to the 3 waves of the influenza pandemic of 1918 and 1919. Hopefully, we'll be able to apply what we are learning right now to the successive waves as well as to future pandemics in our careers. This is my email and Twitter handle. Please feel free to contact me if you have any questions or comments. Be safe, everyone.